To the final Policy Exchange Fringe event of Conservative Party Conference. My name is Robert Eade. I am Head of Health and Social Care here at Policy Exchange, and we are really delighted to be putting on this fringe event in association with Impact on Urban Health and the British Heart Foundation, and it is entitled Creating Healthy Places, How Can the Conservatives Improve Health Across England? I'm going to introduce our panel in a moment, but just briefly to set the context, we know that the Conservative Party, when they won a landslide in 2019, made levelling up a centrepiece of their programme. And when it comes to health, it's easy to see why. There are big variations in the quality of care received, and overall health outcomes are really pronounced. Coastal communities, for example, will struggle to often access their GP and experience a higher burden of preventable ill health. But also urban communities face specific challenges too, whether those relate to higher waiting times for planned care in some cities or worse air quality. In London, for example, nearly a quarter of children are considered obese, which is ahead of the average across England. So how can we close the gap in health between different places? That's what we're hoping to sort of find out today. Part of this is about the NHS, but I'm sure you know that only about 20% of your health outcomes are actually reliant on your interactions with formalised healthcare. It's also about the type of job you have, your educational life chances, and the choices you make through your life. So ideally, we'd spend about 20% of the time for this fringe discussing the NHS, and the rest we can think about some wider policy responses. I'm going to now just introduce our speakers. So to my right-hand side, I have the freshly minted new Minister for Public Health, Women's Health and Mental Health, Dr. Caroline Johnson. On her side, we have Anna Garrod, who is the Director of Policy and Influencing at Impact on Urban Health. To her side, we have James Cracknell, OBE, who is double Olympic gold medalist and a Policy Exchange Senior Research Fellow previously, having led our work on obesity back in 2014-2015, and recently ran the London Marathon on Sunday and seems to have paid the price slightly, James. I hope your heel's not too bad. And then to my left-hand side, we have Dolly Theis, who works at the University of Cambridge and has written extensively on obesity and the Conservatives' approach to it. And then lastly, Dr. Charmaine Griffiths, who is Chief Executive of the British Heart Foundation. So I'm now going to invite the Minister to open with a few thoughts.
Thank you very much, and thank you very much for inviting me. This is the first such panel that I have done as a Minister, so I would say I'm looking forward to it, but I'm not entirely sure that that's completely true. So I wanted to start by just saying that we are one of the most healthy countries in the world, and we do have the benefit of the NHS, which is the envy of the world, and really the fact that we have healthcare free at the point of use based on clinical need and not ability to pay is something we should all be extremely proud of and work really hard to maintain. But there are significant inequalities in healthcare. I represent a very rural constituency, and there are significant challenges that we need to face in delivering healthcare to people who live in sparsely populated areas. It's much easier to deliver healthcare into urban areas because of the geographical location of the population. We also have quite a number of challenges between the richer and the poorer in society. I was quite shocked, actually, to read that the difference in lifespan between the very richest women and the very poorest women could be as much as 19 years. That's a phenomenal difference and something that we need to work very, very hard to improve. We're also looking at trust. Much has been made of the ambulance waiting times, and it's really important that if you call a 999 ambulance, that it's immediately, or as immediately as possible, available to you. But we've seen some quite long waiting times in the news and some patients who've suffered as a result, and we need to make sure that stops. That's why ambulances of the ABCDD is one of the Secretary of State's highest priorities. But we also know that 45% of those delayed ambulance times occur in only 15 trusts around the country. So stripping back the top-line figures and going underneath and saying, where does the problem lie, will help us to improve our response times. We also need to look at the differences between males and females, because we do know that women experience some health conditions differently. I'm not just talking about the sort of gynecological conditions, but things like heart disease. Many presentations of heart attacks, for example, can be different in males compared to females. And so much of our research has been based on males that actually the outcomes in women can be less good, and that's something we need to look carefully at. We also need to look at prevention. You've talked about obesity already, but obesity and smoking are the biggest preventable causes of disease and death in our country, and we need to work hard on those. And then I just want to talk about vaccination. So we know that in some areas of the country, vaccination levels are not where they need to be, and particularly the preschool booster, we're not achieving the levels of vaccination that we would like to. And when you actually peel again below the top level data and say, what are the figures in each geography, what we find is there are specific areas of the country and specific groups that are less likely to be vaccinated than others. And it's by going below the top level data to the more sophisticated, more higher level of detail, we will work out where the nub of the problems lie and how to resolve them. And I think overall data is the key. We hear a lot. The NHS, the debate is always about how much we're spending, who's spending the most, how many staff are in how many places. But actually, by putting the patient first and by looking at outcomes for patients as opposed to inputs, that is how, in my view, we will help to improve the health service. Thank you. It's my time.
Thank you, Caroline. Yes, you kept to time, which is excellent. I want to just ask one follow-up question, because obviously your own clinical background as a paediatrician gives you a huge advantage. I noticed the Secretary of State referenced you as the in-house doctor as part of the DHSC team, which is fantastic news. Yeah. Obviously, childhood obesity is something that has grown worse over the pandemic, and I think the statistics, and obviously, as you said, the data is important, do bear this out. Have we got the right policy framework in place around childhood obesity, or is that going to be something that you'll be making a priority or somewhere an area of focus in your time in the department?
So childhood obesity is really important. If we don't set children up at the very start of their life for a healthy life, then when we're doing them a great disservice. Getting those habits built in for health early on will pay dividends in the long run. This is not just a health department. The challenge of childhood obesity is a great one, but it isn't going to be just solved by health. It's much broader than that. And we have seen some new policies come in, and you may have noticed your supermarket shelves have been redistributed over the last few weeks, and that's because a new law has come in that prevents high-fat, salt and sugar products being marketed to children on the ends of aisles in certain places within supermarkets. And the evidence suggests that that will lead to reduced consumption by children in particular of these products, and it should reduce the number of calories taken. You may have been to a restaurant while you've been out in conference and noticed that the number of calories is now displayed beside the products that you want to eat, which in some respects is a great thing, because it means that you can make an informed choice. It's not telling you what to eat, it's giving you the information that you need to make that informed choice. And certainly when parents are looking at what their children are eating, they can make informed choices. It's about education, it's about making sure that the easiest option is the healthiest option. In some cases at the moment, the easiest option is not the healthiest option, to make sure people can access high quality, affordable food.
Thank you. Anna, could you please give your opening thoughts?
Yeah, hi everybody. So Impact on Urban Health are one of the UK's largest charitable foundations. We have an endowment of 1 billion and we aim to improve health both through how we invest our endowment and how we run our property portfolio, but also in our philanthropic work, where we take a long-term look at some of the most complex issues that occur in urban areas. And so what I'm hoping to bring to this discussion today is what we know about what works about improving health in places. So a place-based approach to working to improve health. We work in Lambeth and Southwark, which is a really interesting place to be working, because Lambeth and Southwark is a microcosm of Greater London in terms of demographic makeup, diversity, income, across all sorts of measures. So it's a great place to test what might work to improve health and then look to scale that across the UK and talking to others in cities around the world too. So 3 things we know from our work that can impact on health in places. As Robert says, the places that people live and work are what shapes our health. And to give a really kind of real example of that, 2 in 5 babies born in this country, their first breath that they take is toxic air. And so when you think that my own daughter was in NICU for a few weeks when she was born, and literally tens of thousands of pounds were spent on her care, but the whole time she was breathing toxic air, it really brings it home how real that kind of cost benefit is when you think about the places we are and then the services we're trying to provide to improve health in those places. And the job for Caroline here is to think about her role in speaking to the rest of government in terms of what they can do to improve health. So colleagues in BAYS, in DEFRA, and think about how we can kind of get that cross-sector action on health. I think to Caroline's point on data as well, in terms of improving health, you need to know your place. And in Lambeth and Southwark alone, you can walk 12 minutes and the life expectancy will drop by 12 years. So from Dulwich towards Peckham. And that's not mysterious. So you can look at drivers of health, and we have something called the Urban Health Index for those data nerds out there, which measures 42 different metrics of health and well-being and layers them on top of each other to work out what's going on at very micro neighbourhood level in terms of people's health outcomes. And we know things like, things like smoking impacts on health, but also your opportunities to volunteer in civil society, that has an impact on health outcomes too, as well as education, housing, what sort of work you have. All those things shape our health, and the data tells us about that. So the information is out there, but we need to spend much more time understanding what's going on in places. And a large part of that is talking to the people who live in places as well, because they know best what they need for their health. And then finally, we work with statutory services and we work with community sector too, but where there's most untapped potential to improve health is when we look at the role of industry and investors, both at a micro-local level, so the convenience stores where families are buying their food, but also those large employers whose shift patterns impact on the health of millions of night shift workers, for example, who are more likely to suffer from obesity, cardiovascular disease, but also more likely to get divorced. So 6 times more likely to get divorced if you're a long-term night shift worker, which then impacts on your health as well. So just encouragement for people to think outside those kind of classic spheres when we think of health improvement, so the charities that are doing great work, but what businesses do we have in a place that can really drive health improvements in their employees, but also the environment.
Thanks, Anna, and really good to hear about what some of those actors and enablers are that we might be able to have at our disposal. James.
Yeah, good evening, everyone. I'll try and keep it fairly simple. I looked at it from the angle of levelling up and then the levelling up agenda, and a lot of them have been made of levelling up economically, but actually the regional health variations are pretty stark. And the Minister's already explained, and Anna as well, that if you take, say, Blackpool, the average life expectancy of a boy born today is just under 54 years, whereas if they'd been born in Richmond, in Surrey, it would be just over 71. And the reality is that more affluent areas are more physically active. And I don't want to sit here as an ex-sportsman thinking that exercise is the route to a long life. It is part of the process. And I don't think any GP would, if they could give the benefits of physical exercise on the heart, the lungs, osteoporosis, and the mental health in a pill, they wouldn't do it. But it is one part of the big problem. And the reality is the UK now is less active than any time in its history. And as an example, only 20%, so by New Year's Eve, only 20% of the country will have walked 1 mile continuously once a year. So you think 80% of the people aren't walking a mile without stopping each year. And that sort of gives an impression of the scale of the problem. And the reality is that the next generation, as it's been said, aren't going to save us, because they're already heading down the same route by learning the behaviour that their parents and society are putting in them. And the reality is that by the age of 5, people in poverty are twice as likely to be obese. And if a child is obese at 11, they're going to be 80% of obese 11-year-olds will be obese adults. So we have to get that behavioural change and the good patterns in life early, and that comes from the National Childhood Measurement Programme, which currently measures at year 5, and then when you leave primary school at year 11. So there's a 5-year window where there's no measurement taken, and if a window where there is no action taken leads to problems that can't be reversed later on. And the problem with the engagement is that parents, if they're age 5, if your child is overweight, you'll get what's known as the fat letter, which then disengages the people from helping out and seeking the help. And that's the important part, is to take people with you, educate them. By measuring them every year, you reduce that window as a black hole where irreversible damage is being done to children. And the other area I thought about was GPs, because that, I know it's not an NHS discussion, but it is the primary point of contact most people have with the NHS. And in the training that, again, the Minister may be able to correct me, but the training that a GP has, there's less than a day on nutrition training. And nearly 75% of GPs don't discuss the benefits of physical activity with their patients, and actually 80% of GPs are unfamiliar with the physical activity guidelines. And so I think the local authority should work in tandem with the GPs to actually promote a sort of inclusive group to install those good habits. And it's also education, and the Minister mentioned calories, but actually what people can see a calorie, or what calories are listed on a menu, but what does a calorie mean? I don't think it's a number, but what does that number mean? If another alternative would be a can of Coke, you have to walk for 35 minutes at 3 miles an hour to burn off a can of Coke. And to burn off a slice of Domino's pizza, I don't want to label Domino's as the bad pizza, but that's 45 minutes. So if you're having 2 cans of Coke, 3 slices of pizza, you've then got to walk for over 2.5 hours to burn that off. And I think that is a more realistic knowledge to people than an arbitrary number of calories, which people they may know you have 2,500 calories a day if you're a man, but what does that actually mean in terms of how much you move? And if Robert mentioned I did the marathon on Sunday, and I got to the end of the marathon and I'd burnt just over 3,000 calories, which I thought was spectacularly unfair, having run all that way. That's effectively a Big Mac meal. I think I deserve more than that. And that's where calories and food and exercise, you can't outrun a fork. And those are the things we need to get across, the simple things that people can take into their lives rather than too many stats.
Thank you, James. I think after the last 3 days, we all need to go on a team walk around Birmingham just to try and make up for what we've done to our bodies. Dolly.
Thank you, and thank you for having me, because I'm standing in for Baroness Camilla Cavendish, but as I said, I've done so much research on her involvement in this agenda that you can ask me anything and I probably will quote more than she can remember herself. But I actually want to welcome you to the role as Public Health Minister, because I say this hand on heart, I think you are in a really special position. I have not met a single public health minister who hasn't loved that brief and has not ended up becoming sort of completely committed to the agenda beyond it. So I really hope that you enjoy the challenge, even though it can feel like a pretty tricky area. I think it's an amazing area of policy to focus on. And you've got a big group of organisations around who will do everything they can to support you in that. But I want to kind of give an overview of the government policy history and to give a context to how my interest in this area of research came about. I was doing my PhD already looking at how governments make public health policies. But what really struck me in 2020 was when Boris came into government, and if you all remember, he was very vehemently opposed to the sugar tax when he was running his leadership campaign. And then he got COVID himself and came out of hospital and sort of had this revelatory moment where he realised that his state of health was probably a big reason why he ended up in ICU. And so he said he went back on the idea of scrapping the obesity policies that had been introduced by the previous government, and he decided to set up his own. And we at the time, I was working with a number of organisations in contact with government at that time, trying to say, you've actually already had 3 government strategies proposed under a Conservative government alone by that point. You do not need to introduce another one. But then all the political reasons about a new government coming in and wanting to own their own agenda, fair enough, you have to do it all, but we want to make sure that this isn't used as an opportunity to scrap the policies, the strongest policies that were the most contentious at that time. And so we had this close relationship and ended up with a strategy which is still sort of what's being implemented at this time, and contain the strong policies as well, and it sort of can be considered world leading in many ways. But it really sparked for me this question of how is it that you get even new Conservative governments, having been essentially from the same party as the previous government, coming in and scrapping policies that had been well considered and introduced by their colleagues. Why is it that we're in this sort of nightmare policy cycle where things don't end up falling through? And really looking back at the issue and trying to figure out why is it that issues like poor diets don't actually get solved. We've had, I was looking at histories of policies back as far as the early 19th century. So I started in sort of 1802, 1803, 1902, 1903, and looking at it up. 1802, 1803, starting from that point and looking at what kind of policies have been introduced and seeing this cycle again and again over governments, whether it was on the same party or not. And then decided to do this analysis, which I was surprised hadn't ever been done before, almost on any government area in this way, which was to analyse what government policies have been proposed on the obesity agenda to date, and to try and understand why it hasn't resulted in any improvements in the area. And what I found was astonishing, and this research has been used in various ways since. But over the last 30 years, so since 1991, 1992, which was when the first sort of formal obesity reduction targets were introduced by government, we have had almost 700 individual policies proposed by government, and yet no reduction in the obesity prevalence or related inequalities. So this huge number of why is that? Why does that happen? And there are various reasons why that happens, and I will say them very briefly. I'm very happy to go into any of them in more detail during the discussion. The first one is that they're proposed in a way that's unlikely to lead to their implementation. So they're proposed tend to be as like very nebulous statements. The government wants to take obesity to the world stage. Like, what does that mean? Who's going to actually see that through? What's the time frame? Whether it's something that isn't proposed with a cost, for example. Then you have an issue that the actual policy ideas, the largest proportion of them are unlikely to be effective and equitable. So even if they then are seen through into implementation, the nature of the policy ideas proposed are unlikely to be effective and equitable. And then finally, you have this political situation where it clashes with the belief systems more often than not of governments. So there is this absolute reticence to seeing through these policies because there is a fear that it's nanny statism or whatever it's perceived to be. So you've kind of got all the cards stacked against the implementation and progression of these policies over time. And so we end up, for a Conservative government that wants to be seen as sort of resourceful and good government, etc., an enormous amount of waste when it comes to the policy cycle and just not seeing through these policies again and again. So, and we're also in a position now where it not only looks like we're just getting the policies scrapped, we may not even have a government that's interested in promoting policies on this agenda. So we're sort of in a position where we don't know what's going to happen next. But I would sort of urge ministers going into this role that the policy ideas have been so well considered and so thought through over so many decades that they're sort of there for the taking. And it's about the seeing through of these policies that are already being proposed again and again, time and again, even among the Conservative governments alone, that we just need that progression to be made.
Thank you, Dolly. And I just want to pick on one thing, because you said that sort of there was a potential risk that the government would not be as committed to this agenda. I just want to take that question to the Minister, because there have been reports in the past week about potential watering down or maybe not prioritising particularly the disparities white paper. Is that the government's approach, do you think?
I think the government actually remains completely committed to making sure that we reduce health inequalities, we make the population healthier, and we reduce childhood obesity. I'm looking at the ways in which we can do that. And by the way, I agree with you that what we need is action and outcomes, and strategies are a great way of developing policy in areas that you might not have looked at closely. But once you have looked at those areas closely, what you then need to do is act, and that's what I'll be looking to do.
Thank you. We have focused quite a lot on obesity, but it'd be nice to talk about the wider public health agenda, including things like respiratory disease and heart disease, of course. So, Charmaine.
Thank you, Robert. And I think I'm going to agree violently with much of what's been said, but I'd like to start by welcoming you to your role as well. The British Heart Foundation has been tackling inequalities for 61 years, and as the largest independent funder of cardiovascular research, we're really passionate about making a difference. And I guess the first thing, if you'll let me share a few things that are important to us, I would say is we firmly believe that where you live, what you do for a job and what your ethnic background is should not determine your health and the quality of your health and life. So that's our kind of starting point. And we really have seen during the pandemic how the pandemic's laid bare the kind of tectonic lines of inequalities more now than ever. And sadly, cardiovascular disease contribute to a quarter of the difference between those most and least affected. So it's an issue we're hugely, hugely passionate about. And I'm really pleased to hear you talk about the priorities that you're focused on, because for us, it's really imperative that the government brings forward the Health Inequalities and Health Disparities White Paper to give a framework for all of us to coalesce around and work towards. And do you know, I've been pleasantly surprised by some of the discussions we've had over the last couple of days, and particularly the coupling, and we were at a discussion last night, the coupling of the focus on health with economic wealth. We truly believe that there is such a firm connection between the right thing by people and their health, and will have a fantastic impact in terms of productivity and economic gains as well. That's reduction in costs, but also people having more productive and healthy lives. And we see them as two sides of the same coin, but there are a few things I'd like to call out this evening just to emphasise as things and steps we believe are really important to making that happen. And the first is taking really bold action on prevention. I don't think that'll be a surprise to anyone on this panel or in this room, but we know we need to take bold steps to keep people healthier for longer, and I've just heard more about the 700, is that right?
689.
Oh my goodness, 689 different policies. Oh, it's making my head hurt just thinking about it. So definitely need to take some bold action. And the other is making sure that we resource the health system to target those underserved areas. And it was really heartening to hear, obviously, that being spoken about in this afternoon's health announcement as well. And lastly, as the leading independent research funder, it might not surprise you to hear that we feel really passionately about diversity in research as well. We need more participants from diverse backgrounds taking part in research to have better outcomes and to make better decisions for people. And of course, the risk factors for poor heart health, we've already touched on obesity and smoking, really are engendered by environments. Others have said that too. So we know we need to make the environments in which people grow up and live healthier. And I know that's the subject of that brings us together this evening. And particularly thinking about the obesity strategy and not scrapping good thinking and good thought, we really feel strongly and compel everybody who can to urge that obesity strategy to be protected because there's some great thought and great work in there. And the idea that some of the steps we've taken forward, whether that be around some of the levies or indeed some of the restrictions on marketing might be under threat, are deeply concerning to us, because I think their economic and health benefit are clearly proven. And I guess I'd build on that by saying I think we really also need to look forward to the support we give people in their communities. It's not one size fits all. We've heard other people talk about the environments that they know and work in. But we know that the funding has been cut for real intervention and support in communities by over £1 billion since 2015-16. And we know this has an incredible impact on the support people need to be healthy or take healthy steps. So we'd love to see that restored. One of the things that really worries us is there have been some big shifts, of course, during the pandemic, but perhaps ones that aren't so obvious are things like looking at the number of people who are being treated for blood pressure. We've seen an absolute plummet in the number of people who have managed blood pressure treatment. It's dropped by about 2 million people. They've not gone anywhere, it's just they're not being treated, and that potentially causes up to around 12,000 new heart attacks and strokes that could have been avoided over the next couple of years. So in terms of health interventions, things like getting back on track with health blood pressure checks is super important to us. So I guess to come to wealth and the cost of it, it's astonishing to think that heart and circulatory diseases cost the NHS around £7.4 billion every year. And without the services available to people living with heart and circulatory diseases, that's only going to get worse. So I think the argument for investing in prevention and protecting hard-earned prevention positions and policies has just never been clearer, I think, for us as a UK. And obviously just making sure that we truly unlock the benefits of progress through making sure we've got good representation in research. You'd expect me to say that. I think it's absolutely critical for the future as well. I guess my last thing would be able to say there's not many simple answers in this. The fact we've got so many smart people in this room and in the conference over the last couple of days talking about the importance of health and connection with economic value as well is testament to the attention it deserves, but also how complex it is. But I think we just can't afford not to do it. I think we have a real moment post-pandemic to grip even the health agenda, and I think absolutely this is the time to do it, to make a difference. Thanks, Robert.
Thank you, Charmaine. I want to actually just ask a question to the panel before we go out to the audience about the politics of it, because we've heard lots of compelling statistics from everyone here, which arguably sort of should normally win the argument by themselves, all right? But we, as Dolly highlighted, we've been pushing at this agenda for many years, indeed centuries, and have not seen the results that we wanted. So how can we make the politics work? And James, you're someone who's prominent within the Conservative Party movement. How can we make this a Conservative message that will endure across political cycles and indeed the change in governments that we're having between 5-year terms at the moment?
Well, I mean, far from an expert, but in terms of the policies that are needed and then the change that's going to happen is going to take more than an electoral cycle. So a party has to take the bold step that the benefits from the right policy may be felt 10 years down the line and by another party, but it's actually for the good of the nation. I think that's where it has to be, cross-departmental within the government, but then cross-party as well. And that's, it's going to take a generational change. And so much at the moment is with the economic changes from last week of who's going to pay for it down the line, as has been explained up here, the cost of not doing this right is going to hit us as hard as anything else. And it's going to require a brave party to say, look, we're going to put this in place. We might not benefit from it at the next election, but society will benefit from it down the line. And I think that's where good leadership comes in. It's for the good of the country rather than necessarily the short-term good. And as Dolly's highlighted, it changes from administration within the same party. So I think someone needs to say, right, get the right policies and then put it in place knowing it's good for the country. It may not be good for your party by the next election.
Minister, it'd be great to get your thoughts on that question.
Well, I mean, I think with healthcare, yes, too often politics comes into health, but actually the reality is we know what the right things are to do. When it comes to preventative medicine, we know that if we can prevent ill health, it's good for the patient, it makes them better, stops them being a patient, and good for the person, makes them better, stops them becoming ill. But it's also good for the economy because that person will then be economically active, they'll be well, they'll have good mental well-being. Those around them won't need to provide them with additional care, which is good for their mental, physical well-being as well, and good economically too. So this stacks up not just in a moral sense, but in an economic sense as well, which is why I think prevention is so important. It is cross-departmental, which makes it more complicated to deliver. I would agree with that. And I think there are differences between adult and children. So there is resistance in some quarters to sort of nanny statism towards grown-ups, saying to people, you're a grown-up, we're going to inform you of what will most benefit you, will make these choices easier for you to take, but ultimately those choices are yours to make, as opposed to children where I think people are naturally more nannying. We naturally want to make sure that children are well, and in particular for kids, if we set them up properly right from the start with good healthy choices, they will go on to live a healthy life. I think James that said that 80% of children who are obese as young children will grow on to be obese adults. So that's where we need to, from my perspective, we need to intervene to ensure that children can have a healthy start in life.
Thank you. Thank you. Well, actually, I'm going to go into the audience in a minute, so thank you. Thank you for your contribution.
That's actually a very interesting point. So there's over 50% of kids who live within 400 metres of school get driven.
Thank you. Without a microphone, sorry, we can't exchange in dialogue at this moment in time. But if you're able to hang around, we'd love to get your question in a moment's time.
That is actually one of the tougher things to deal with, because they're living longer. Whatever you say about things, the one thing medical science has done is made us all live longer.
Thank you. Yeah, and maybe we'll get into ensuring that sort of. I know that the government's got a manifesto commitment, for example, around healthy life expectancy. So increasing the proportion of your life expectancy that you enjoy in good health. So maybe we can discuss what the plan is to get there, because I know it's quite a punchy target, and we haven't got that long. And I think sort of the latest estimates are that we would miss that target by a number of decades. Could I maybe come to Anna and then Charmaine? It'd be good to get your thoughts on the politics of this and how do we win people over with storytelling? Can we use the force of economic figures to win this argument, do you think? What's the right through? Maybe Anna first.
Yeah, I mean, it's a really important question, and actually I think there's a solution. So the message is about opportunity. I think everybody in this room would agree that everybody should have the opportunity to be healthy. And too often we get into debates about, telling people what to do. But if you are say a single mum and you have 2 jobs, and you are juggling childcare and insecure housing as well. We've done surveys. We know those mothers know what to feed their children and desperately want to feed their children healthy diets. But if you live in an urban area where you're surrounded by fast food outlets selling really, really cheap, incredibly unhealthy food, and convenience stores, which are, we've all been into our local convenience store. We know what fruit and veg is available, and the answer is not very much. If you're surrounded in these kind of food deserts where there just isn't a healthy, affordable option, then you have no opportunity to feed your children those healthy foods, especially when you're carrying that cognitive load of the life stresses I just mentioned. You can't then make the time to go and travel to kind of work out how you're going to make your food budget stretch. Because of that cognitive load. So, Robert, I think it's about the language of opportunity, but also it makes economic sense, and the solutions can be good for business as well. And we've shown by working with Tesco's that you can change store layout, you can improve the healthiness of shopping baskets, but also maintain profits. And that's the message that's going to cut through. And investors increasingly know that. They know that corporations that take action on health are going to be sound investments for the future. So,
well said. Oh my goodness. Do you know what? I think all big change that really matters is a combination of head and heart. And I think we're way beyond the point of arguing about the data. I think all of the data we need, we have. So I think it is a combination of storytelling about bringing the issue to life in an emotional way. And my goodness, having heard people who've lost loved ones, people who've lives have been really devastated by cardiovascular disease that could have been prevented in a different world. I'm sold on both the head and heart. And I think that's why we're really looking for consistency, whether it be the obesity strategy, sticking to it, delivering it, or the health disparities white paper, publishing it and holding ourselves to account for delivery of it. I think we're beyond challenging the data and even beyond the fact we need to do it. It's just about committing as an ecosystem to getting something meaningful done. And I'm encouraged by the conversations we're having over the last couple of days. I think we're at an inflection point and look forward to having discussions with the leadership about how we stick to it, because we're not having to choose between health and wealth. We can have both. Got the data, got the stories, got the compelling political and economic argument. So I think it's up for the grabs.
Dolly, do you want to come in at all?
Yeah, this is my main focus of my life at the moment, is trying to get the politics of this whole feels like. But it is really exciting, and again, I would say to the Minister that this is probably the main challenge you'll have in this area, is that there is a fundamental perception barrier that works against this agenda time and time and again. And it's why you more often than not, and I almost say like 99% of cases, you'll have particularly people within the Conservative Party, but actually it's much broader than that, who get converted to this agenda. So the starting point is rarely on side. And that's because the perception around government intervention on, I'm going to talk particularly around food, but this applies to tobacco smoking, it's a lot pollution, it has the same narrative barriers, is that it increases, government intervention increases the price of food. If they introduce policies around food, the perception is that increases the prices of food, that it takes away choice, that it's nanny state, it's government telling you how to eat or whatever, and it's literally the opposite of all three. If you look at carefully designed policies, the ones that have been proposed, it is the opposite of all three. You have policies that are there to make food more accessible to the lowest income families. When it's like the SDIL or sugar tax as it's commonly known, it is not about increasing the prices of products, it's about incentivizing companies to take out the sugar, to reformulate them and hopefully keep them at the same price, which we have seen be the case. And the business sector itself has thrived because it's diversified the product portfolio, and we've seen that the market has not been impacted at all. In fact, it's benefited, and we have particular companies that have grown as a result of the SDIL. When it comes to taking away choice, it's also the opposite, because this is about enhancing options available to particularly people that really do suffer from having low choices, whether that's in the food environment around them, or whether it's in school, or whether it's in promotions and where the spotlight is shone by companies on certain products and not on others. And when it comes to the nanny statism, we're not even telling people, or most policies that are sitting within the most effective and equitable policies aren't about telling people what to do. It is about creating conditions in which those options are just simply more available. It's easier, more affordable, more accessible for families to reach. So it's very frustrating for people in public health that know that about the policy designs. And as you say, the data's not the issue. We've got that and we actually know what needs to be done. It is the perception. And so creating these positive narratives, particularly that are politically salient around this, is a big challenge. And there aren't that many policy champions within this agenda. You don't really get politicians coming in and going, obesity is going to be the thing that I'm going to build my legacy on. So luckily, we've got more voices. Basically, all the ex-public health ministers are your biggest champions in this. But we've got amazing people like Michael Gove, Lord William Hague, who are coming out so strongly to reframe so that we talk about health as the foundation of freedom, that you cannot have a strong economy without a strong, resilient population, that the cost to the NHS, if you've got a population dying earlier and spending much more, in fact, the majority of their life in poor health, which is the case in some of the most deprived communities, that is not the conducive setup for a strong economy. So we have voices coming through, but we are nowhere near the numbers or the loudness level that we need, that it's being received in that way. So this is sort of a call for more of those voices to be convened and heard, and until we get to that point, we're not going to win that. But I would point to someone in the audience, Tom Hashemi, whose job and business is around creating these kind of narratives, and that is exactly what we need more of. The policy recommendations alone are not going to convince and persuade people that are not in this agenda. So we need those narratives and those strong stories, and that political alignment.
Wow, what a tour de force. Yes, thank you, Dolly. We've got about 10 minutes or so left, and I'm keen to give an opportunity for people to ask questions if they wish. So we've got one hand up at the front, and then we've got one hand. Actually, maybe, Claire, if you just go to the gentleman first, and then we'll go to the front afterwards.
Thanks. James Illman from Health Service Journal. So, Dolly, you made a really kind of cogent argument around how policy goes round and around, and it's very inefficient. You made a very cogent argument about why the health disparities white paper shouldn't be scrapped. Minister, you made a very kind of cogent argument around health inequalities in the agenda, but you didn't go as far as to say that you were committed to the white paper. And I appreciate it's a vehicle and it's agenda, but I feel like it's quite an important distinction. Are you committed to the white paper? Or, it just feels like some clarification.
We'll just take the second question and then we'll come back out. Thank you. So, commitment to the white paper, and then just at the front here.
Hi, I'm Christina Mellam, and I'm the Chief Executive of the National Association of Link Workers. So I think we shouldn't be obsessed about white paper or no white paper on health inequalities. These are things we need to deal with. And I wonder whether we're designing services for the few, because I'm just sitting here as a BME woman who needs to lose weight, and I just feel that some of the things that are being discussed is almost I'm not able to do that. So, for example, we have a digital weight management program for the NHS, and in January, my GP sent me a test, and they gave me an option to go online to help me lose weight. And I wasn't given any choice. I want to ask questions. So I think that we have a challenge where we're treating public health and prevention as a product and a commodity and not understanding the context. That's the reason why we're not able to actually get traction, because people want to talk about what matters to them. And we've got social prescribing, which is brilliant. It's part of the NHS long-term plan. We've got 4,500 commitments from the government to recruit this. Why are we not speaking to the social prescribing link workers that are working with the people who are experiencing all the things you're talking about? So what you're getting is a mismatch between policy and what is going on the ground. And if we're going to stand up for patients, it has to be what matters to them. So in as much as people want me to lose weight, it has to be what matters to me. And until somebody's going to sit down, understand the context, proactively supporting people to overcome the disadvantage whilst looking at the structural barriers, we're not going to get traction. And the challenges that we face...
Thanks. If you could just conclude with your question, that would be great.
So my question is, are we treating public health and prevention as a product and a commodity and not the context? And what is it that we need to do around making sure that we're proactively supporting people and doing that by supporting social prescribing and the community infrastructure to enable that?
Great. Okay, I will give the Minister the opportunity to respond to those first two questions, and then maybe we can bring people in for their thoughts. I think especially around the kind of narrative and how do you bring people with them and meet them where they are would be a really interesting topic to explore.
Thank you. So in terms of the various different papers, no papers, I think that the key thing, and going back to what Charmaine said earlier on, is actually action. What I want to see is action to help rather than necessarily papers and documents and such like. You don't need, as Dolly has suggested, you don't need to convince me that we need to improve the health of the obesity to improve health, because in my NHS work as a consultant paediatrician, I have over my time seen a 9-year-old that weighed more than 85 kilograms and a 12-year-old that made more than 120 kilograms. And I've seen the health effects and the challenges that those poor children faced as a result of the morbid obesity that they were living with. And so I'm absolutely committed that this is a significant problem that's affecting the health of our children and the fact and going on into adulthood that we need to deal with. So please understand that I'm completely on board with that. I listened to what you said about the digital weight management problems. I'm not completely au fait with all the different types of weight management schemes that we have running at this stage, but I will look at that and make an assessment of it.
And obviously very encouraging, I guess, with Therese's comments about being on the side of patients. So she's made that very clear that she wants to listen to patients' concerns and sort of start with their needs as a priority.
Yes, absolutely. I mean, it's about putting the patient front and centre, putting the patient first, getting good patient experience and looking at patient outcomes rather than inputs, so that we can make... At the moment, we spend a lot of time looking at inputs. We need to look at outputs and how it affects the patient. And that's what we'll be doing.
Charmaine, did you want to come in on that, on either of the points?
I think it's a really important point to understand what people need and what matters to them. That really resonated with me as a charity responsible for being the voice of 7.6 million people with heart disease. We know there's so much difference in both communities and backgrounds in there, and so many different drivers. So I think you're really right, and which is why we're, perhaps I called out the stat earlier about why we're so concerned about the cuts to kind of support and services within communities. I think the balance of having really clear central priorities and frameworks for which we can all align, but then making sure we've got the resources to work within communities. So we are working with whether it be geographical differences or just people's background or heritage differences, we're giving people support to do what matters to them. Because every community has its unique and different challenge, so I think it's a really great point well made. Thank you.
Does anyone else want to come in on that point? Otherwise, we can go out for questions. Anna, would you?
Yeah, that's a really, really important point about what people actually need. and meeting them where they are. And we have a scheme called FinShield, which is established through social prescribing services, and where we use data from GP practices to identify people with long-term conditions who we know are at risk of financial precarity. We know that if you have a long-term condition, it's more difficult to stay in employment, you're more likely to have insecure housing, and you're more likely to be in debt. So through this model, FinShield offers people with long-term conditions proactive financial support and advice, which includes if they have a health crisis like needing to go and have an operation, negotiating with the housing association a rent payment holiday for that time, so that the health crisis doesn't become a financial crisis, which then we know spirals downwards. And so that's an example of meeting somebody where they are, which is you don't just have a health condition in isolation, you also have financial situations and housing situations that interact with that health condition, but also joining up services as well, so that somebody isn't then going to have to seek the support from multiple different places.
I think our marquee is going to turn into a sale, so it's probably good that this is the last fringe that we have. Have we got any more questions out in the audience? We've got one arm there, and then we've got one arm in the third row.
Thank you. I just want to say it's been a really interesting discussion this evening. I just had a question.
Could you introduce yourself,
Oh, sorry.
please?
My name's Lucy Mowat. I'm from Battersea. My question was, so we've talked a lot about the obesogenic environment, and I just wanted, do you think that the government is able to sort of get industry on side without going down the route of more taxation? For example, like the sugar reduction programs, reduced sugar, has had some success, but actually chocolate confectionery, for example, sales have gone up. So we see things like those big sort of bars of chocolate at the end of aisles, things like that. So do you think we can get there without going down the route of kind of legislation? And just to comment on something else is, I'm one of 9,000 registered dietitians in the country, and when government talks about healthcare staff, they often talk in the context of doctors and nurses, and actually you could have dietitians that patients could be triaged at GP surgeries to give dietary advice. You've got physiotherapists that patients with MSK conditions could be seen to help sort of improve physical activity, that sort of thing. So that was just another comment that I just want. Pharmacists that could be monitoring blood pressure, and I do wonder if that's the sort of bit of untapped potential as well. That was just an additional comment.
That's really good, and obviously it's been interesting to see the Secretary of State highlight for community pharmacy, for example, doing more in some areas, so maybe they could have a role. And we'll just take the second question and then we'll throw them back to the panel, and then we'll probably have to summarise as well at the same time because we're coming up to 1:15.
Thanks very much. A great panel. Sean Phillips, Research Fellow in Health and Social Care at Policy Exchange. I just wondered if one of the challenges with particularly the public health element of the discussion, that actually there's a problem with defining responsibility for action on the agenda. So many of the policies, for instance, that you will have analysed, Dolly, actually, part of the challenge is that it doesn't sort of touch ground. And, Anna, you'll have seen this with the work that you're doing locally. That sort of local intelligence is really, really critical. We haven't heard a huge amount about the NHS's role here as an anchor institution delivering things side. And then obviously, clearly we can sort of point to our politicians and say, there's that political accountability for the delivery of these agendas and certain targets. And then individual responsibility, of course, as well. So I just wondered whether there is a bit of a challenge, actually, in really keying in on responsibility fundamentally for actually delivering on this agenda and people being able to sort of push side to side sort of as part of the challenge.
Okay, so we've sort of got three different areas then. So we've got the kind of bringing industry with you and sort of not making it a negotiation rather than a lobbying battle over legislation. We've got the sort of the opportunities around workforce and plugging in, and then who's responsible? What's the role of the state? Where do we delineate as well? James, maybe I'll come to you first, and then Dolly.
Well, I mean, it's. I think it's industry is going to be a really hard push to get them on side. I think one thing that I have listed here is. In terms of corporate productivity, there's actually employers, the benefits to them and their company to have a healthy workforce actually should mean that they take charge of looking after their workforce and actually putting things in place, because that means less sick days for them and putting in policies. And I think that's a crucial part where that can, you've got a captive audience the same way that you do with school children, although it's not the same as the bottom quartile of society. in terms of the point about, I think it's a really good point about dietitians, physiotherapists being used as part of in the community rather than everything just being done by the GPs. Actually tries things out, and having community pharmacy. It's with my children we have the same with the local chemist, and actually the kids have grown up knowing the pharmacist who actually is effectively does a job of a GP for when they're going there, they know your children, they know what, and you can talk to them about prescriptions or what they should be doing. And I think that's an incredibly useful resource that actually doesn't require the same amount of time it takes to book in a GP. So I think there are things that need to be organised, and I think in terms of it's not quite the same question, it's better to go back one. The policies that are written need to be written for the people they affect most. In terms of healthy eating agenda, you've got 20% of the people in this country, all they have in their kitchen are a toaster, a kettle and a microwave, and 20% of the country don't have a table. So you realise that there's policies that are written for people that need to affect the ones that will gain the most benefit from them, and that's again already the food desert's been spoken about of people can't buy in bulk, so therefore those things need to be taken into account.
Yeah, absolutely. Dolly.
I'll touch upon the industry point.
We'll have to make the comments fairly brief,
Very
by the way,
well,
just because we are out of time. So.
Yes. And I'm always happy to pick this up, and it's lovely to see you as well. So on the industry front, what I would say is that time and time and again, public health responsibility deal type involvement with industry, and you will hear this almost from every new minister will come in and say we will trust the industry to do, and then we'll see. That has been tried so many times, and it's one of the most classic kind of not going back in history and looking not even history, like as soon as last year, the same type of things that haven't worked in that way. The most carefully, cleverly designed policy to date on this is the soft drinks industry levy, and just the way that it was designed completely without industry involvement. The industry involvement can be seen as, they submitted their evidence on what was feasible, whatever. The Treasury knew that. George Osborne, when he was really interested in pushing this forward, designed it essentially with the smallest group of civil servants and special advisors. It was without industry, and it enabled them to intellectually think about how to do this, that with all the right incentives that they needed, without having industry's voice, and even the public's voice, and even the Department of Health's voice on this space. They got everything they needed, but it was a completely private policy-making process, and those tend to be the most effective if you're going to design something that is truly to get the outcome that you want. And the other thing that you mentioned is sort of unintended consequences. That is inevitable in such a complex system. It doesn't mean nothing should be done. It's knowing, okay, we know that there are going to be lots of intended and unintended consequences. How can we monitor that and make sure that we adapt? And one really good example is snack size things. So they tried to do portion size, and then what did the industry do? It produced a whole load of snack sharing bags, and the idea, like, yes, we put share on it so it's for multiple people, when their own data shows that people do not end up sharing most of these things. So you can have a well-intentioned policy that has exactly the opposite effect and actually enables the industry to increase consumption. And on the government side, in terms of getting this across the departments and making sure that responsibility is really, really clear, it is so challenging. But I would say that the public health minister position is a very, very good one when it comes to identifying where that responsibility sits. And often when number 10 owns these agendas, it is absolutely seen through, and you kind of need that. And the fascinating thing with the Treasury, when it's on board, you end up with beautifully designed things if it's done in that way, because you're really looking at it from that feasibility perspective. So getting that is the minister's challenge, but I would say an exciting one.
I like the optimism. Charmaine, final thoughts.
I don't think we have a choice but not to act and act in alignment. So to your point on responsibility, I think we're all responsible for this. It's something affecting every family, every community, and all of our futures. So it is the moment to act.
Thank you. And then Anna, and then I'll give the Minister the final closing remark.
I'm going to respectfully disagree with James and Dolly, because the corporation...
Well, we like disagreement. That's good. That's good.
The corporations we work with, the large supermarkets, the food industry, They are privately anyway much more positive than you would think about this, because they see the writing on the wall. They know the policy is going to come eventually, but they also know investors are pressing them for action on health as well. So we have really positive conversation, and you only need to look at Sainsbury's and Tesco's this summer when the government rolled back on bringing in restrictions on the promotions of high-fat, salt, sugar foods, and they just said we're going to do it anyway. They'd done all the work, and that's the other thing we forget. You know, when we roll back on these policies, a lot of work has already gone into working out how they're going to happen and be put into action. So yeah, I'll end on that optimistic note. But I do have a high optimism preference. So,
Caroline, do you feel optimistic?
I'm always optimistic. With industry, I think we've shown that industry and growth can go hand in hand with the desire to improve the quality of the food that people are buying and eating. Sugar tax to an extent has done that, because while we've seen reformulation, we've also seen consumption go up, and therefore profits for those people selling these products go up. But equally, the overall amount of sugar consumption by the population, despite the fact they've consumed a larger quantity, is still lower. So we have had the desired effect of taking sugar out of the diet, which was the purpose of it, so it was effective. It's clearly much easier to do that with sugary drinks that people don't necessarily need to have than with other products, and that's where the other challenge lies. In terms of workforce, I think you're absolutely right that we need to look at the workforce and who, you know, the various talents the different members of the NHS health professionals have, and how they can be most used to their fullness, so that we can achieve the greatest number of patient appointments and wellness. So I completely agree with that. And responsibility, there is an element of responsibility of the state, but of course there's an element of personal responsibility as well. I do think that most people, and I'd include myself as someone who's not exactly skinny, you know, people do know what they should eat, and they do mostly, I think, know what a healthy weight looks like. But it is very difficult, you know, in modern life, if you're working, if you're busy, and as Anna has described, if you have children and families and other pressures, caring responsibilities, financial pressure, housing pressure, to achieve that. And so what we need to do is design policies to make it as easy as possible. You've talked, James, about kitchens in people's homes, as simple as housing design. So this affects all of government. It doesn't just affect the Department of Health. It affects all of government, and it also affects people, because people need to also take responsibility for their own choices as well.
That's an excellent note to end. I'm going to finish with a few thank yous. So first of all, thank you to the Minister for coming, and it's excellent to welcome you to your post, and thank you for generating such an interesting discussion. So we look forward to working with you as Policy Exchange. Thank you to our partners, so Impact on Urban Health and the British Heart Foundation, for bringing this discussion together. And then lastly, this is our last fringe. I think we've done 19 fringes, and our events team have really pulled out all the stops. So I just want to take a second to recognise Oscar, who's been the whizzy guy, making sure that we look as good as possible, and sort of making me good under lights, etc. when I'll be doing my fringe events. Claire, who's been working so tirelessly to pull our fringe programme together, and then people like Lottie, and of course James, our cameraman at the front. They do it on top of their day jobs, and they've done a brilliant programme, so well done to them. I hope you enjoy the remainder of your conference, and thank you for joining the discussion.